Dear friends, today we are going to talk about another important topic. I already talked about the cystic fibrosis symptoms and all. Now we'll move on to the diagnosis. I already said it's a very big topic. Cystic fibrosis, we all thought it's a rare disease, common only in Western countries, particularly in Western Europe, but it's not so. It's been diagnosed throughout the world. And we finished the first part about the symptoms. Now we will move on to the second part, that is about the diagnosis of cystic fibrosis. It is only to repeat some of the slides, may be very useful for the people who are not seen the symptoms. It is a cystic fibrosis is a recessive, autosomal recessive disease. It is a multi-system disease, affect almost all the organ system in the body. It is because of the genetic defect, and one gene, a single gene got defect, that is called CFTR gene. The full name is cystic fibrosis transmembrane conductance regulator gene. It's a very big name and that is defective. Where is that gene? That gene is then in the long arm of the 7th chromosome. What is the function of that gene? The function of that gene is, every gene has some function. Here the function of the gene is chloride transport. You all know in the membrane there are several channels are there, of which the chloride channel is very, very important. And the common mutation is delta 50 There are more than 2000 mutations being now diagnosed, and this is a genetic defect, what I said. And because of the defective gene, the protein also is defective. The protein functions for the chloride channel on the luminal surface of epithelial cells. Wherever the epithelial cells are there, that this chloride channel is there, that is become defective. So naturally the function of that is making the secretions very thin. So because of the chloride defect, chloride is not coming out of the cell. Naturally sodium also want to be in the cells to maintain the electroneutrality. So even water is not coming out of the cell. So the net result is the secretions are becoming very, very thick. It clogs the ductules of the glands, and that is what happened. And most of the glands, particularly the intestinal glands, and as well as in the respiratory system. In respiratory system, the mucosa is made up of mucociliary blanket that also become thick secretions. All these things are all manifest as a disease. Can you see that? This is a very beautiful diagram from the Rockefeller University of cystic fibrosis. This protein is a domain. It contains 1480 domains that are all making together to form the chloride channel. So I already talked about the symptoms. This is the second part. We are going to talk about the diagnosis. Cystic fibrosis can be suspected or screened or diagnosed with all these investigations. Of all, the most typical thing is clinical presentation. You cannot progress to the diagnostic workup without the typical clinical presentation. Of all the investigation, now everybody find it very useful, practical, day-to-day life, it is sweat chloride test. In the newborn period, you can go for immunoreactive trypsinogen, and I am going to talk about that. Then genetic testing and prenatal counselings are very important, particularly in carrier. Fathers and mother are carrier, they want to get a child. There it's very, very important. Some screening tests like aquagenic wrinkling, and some parts of the world they are even doing nasal potential difference, because it is something like electrode assessing the change in the current. I already said cystic fibrosis, the clinical presentation is very, very important. So any child in the newborn presenting with a meconium ileus, or distal bowel obstruction, or neonatal jaundice, or simply teuteria, or child is having a wet cough from the beginning, not growing well, if some child started developing repeated respiratory infections and clubbing, accidentally they found out pseudomonas in the sputum, or bronchitis, or sometimes pseudobarter person. You all know Bartter syndrome. It is a renal condition. It's also autosomal recessive problem where there is a defect in the absorption of sodium, chloride, potassium, like that and all. All these things, any child present, you have to strongly suspect cystic fibrosis to be ruled out. Coming to the first test, I already said of all the tests that pilocarpine iontophoresis is a very important test. It's a very simple one. What they do, they simply pass a small amount of electric current, 3 milliampere, and that carry pilocarpine into and stimulate the sweat glands, and it's a very small amount of sweat, that is 3 microliters are being collected, analyzed for the chloride, and it can be done in a newborn after 3 weeks, and sometimes you have to wait till 1 or 2 weeks, and you can straight away go with the child after 3 weeks. And if the chloride is more than 60 millimole per minute, it is a diagnostic. And anything less than 30 is normal, and anything between 30 to 59, it is an intermediate range. You have to repeat or after some time, or you have to go for genetic testing and all. So I repeat, if the test value is more than 60 nanomole per decent, then it's a diagnostic. Coming to the there are a lot of pitfalls in this test, but I think of late newer iontophoretic techniques are very calibrated, and but anyway, whenever there is a malnutrition or hypothyroidism or GXPD, you have to be little careful, and you have to tell the person. Some mutations are even normal sweat chloride also, that you have to remember. So when the child is very malnutrition, actually you have to be very careful in interpreting this test. You have to repeat it several times, or a competent person should do this test. Coming to the neonatal screening, there are a lot of neonatal screening tests are available nowadays in many countries, particularly in the Western countries. They want to rule out all these problem in the newborn period itself, particularly congenital cystic fibrosis, congenital hypothyroidism, and congenital adrenal hyperplasia, phenylketonuria, galactic sickle cell, all these things. Like that, they also included cystic fibrosis in the newborn screening test. It's very easy for them. What is the principle of the test? In cystic fibrosis, actually the name of the cystic fibrosis itself, cystic means where the cyst occur. Cysts appear in the pancreas. So it destroys the ducts. So the secretions are very thick. That is the reason why pancreatic duct obstruction occurs. The trypsinogen, see, one of the enzyme produced by the pancreas gets leaked into the blood, and by using immunoclonal antibodies, that is, we are going to detect, and anything more than 60 nanograms is considered to be a positive. This test can be done from 48 hours onwards, and only thing is, if the child is extremely premature, you have to be little careful. You have to repeat. Coming to the genetic testing, I don't want to talk much about that, because I said 2000 or 2500 genetic variations or mutations are keep adding, and what we look, you have to look at the 7th chromosome, and the most common mutations are delta F508, and most of these tests are designed previously to target the mutations very common in Caucasians, that is in the Western European people, that is a white people. They say that. That's the reason why if you use the same kit for diagnosing non-white people and all, false negative results may be very high, and these things are very important. A small point about autosomal recessive. Actually, students may be asked what is autosomal recessive. For an autosomal recessive condition, both the parents should be carriers. Father, mother should be carrier. Actually, there should be 2 defective genes. So it is a biallelic presentation. Both father and mother should be a carrier. Then only cystic fibrosis occurs in 25%. In fact, another 25% may be totally normal also, and another 50% may be carriers. This is what this genetic inheritance and all. So if anybody asks, my child is having, I am having a cystic fibrosis, you cannot totally say that no, don't go for pregnancy. only the next pregnancy there have a chances of 25% becoming a normal, or even 50% is a carrier. So you have to give a proper advice. Coming to the prenatal screening, there are two tests they are using. One is the amniocentesis, other one is a chorionic villus sampling. Simply they say CVS. This is an exam question. Which is the better among, is it amniocentesis or chorionic villus sample? And many people prefer this one, and because it is a low risk and it can be done even in around 16 weeks of gestation. If you want to go for chorionic villus sampling, it should be done early, before 12th week of gestation and all. And I think these tests are used for not only cystic fibrosis in screen, many genetic conditions like sickle cell disease, Down syndrome, muscular dystrophy, Tay-Sachs, neural tube, all these things we can go with a prenatal or amniocentesis and all. So when both the father and mother are carrier and they want to see a child, and they can do this test whether that particular child is affected or not. Coming to this very quiz question, most of my students are postgraduates, or I think in exam they ask simply, what are the autosomal recessive conditions? You should be in a position to answer. The common conditions with the autosomal inheritance are beta thalassemia, hematocritosis, Bartter syndrome, Inbar, you have to remember that. And one step ahead, what are the autosomal recessive conditions with a single gene, monogenic mutation? Then 3 diseases you have to remember in your mind, namely cystic fibrosis, sickle cell anemia, renal. All these three diseases are very, very important for the exam point of view. So you have to remember about that. What is aquagenic wrinkling? Actually, there is a nice paper up here from India, and they have done this study, and you can see that in child with a cystic fibrosis, normally if you put your hand in the water, that is RO water, wrinkling may happen, but the wrinkling, it takes at least 8 minutes for the wrinkling to appear, whereas here in cystic fibrosis the wrinkling appear very, very fast. And this in both the 3 diagram, the left one is a normal, this is a normal, and actually they compare between that this is a left, this is a right, left, right, left, right. So you look at the left one, here the wrinkling becomes more and more. That is why they make a diagnosis and all. I think this is not, I have not even done so far. This is a nasal potential difference. Sometimes it's called NPD. It is happening in some parts of the Western Europe. Most of the Western Europe countries where the prevalence of cystic fibrosis is very common, they are doing NPD test, and a reading below 40 is considered as abnormal. That's what. Actually, when I happen to the literature, there are 9 countries in the world they are doing NPD in adolescents to make a diagnosis of cystic fibrosis. Coming to another important question is, you are not able to make a diagnosis of cystic fibrosis even with the screening or newborn screening or sweat chloride. That's a very difficult situation. Only the clinical presentation is something like that. Then what to call it? You are not in a position to make some genetic, or even if after genetic studies you are not making a diagnosis. So till you have a firm diagnosis, or since there is a difficulty in diagnosis in some condition, it has been coined CFTR related metabolic syndrome, CRMS. You can, or sometime before they call clinical CF and all, but the best terminology is CFTR related metabolic syndrome. And here till you make a conclusive diagnosis, then you can use this terminology. I think this is a last slide, and before that I want to say that one thing, and where it is happened mean, sometimes your newborn screening, you are having high immunoreactive trypsinogen during newborn screening, but sweat test may be normal or in an intermediate range. Sometimes the mutations are very, very uncommon till it is not supportive of cystic fibrosis. So all the results might found to be inconclusive, and till make a diagnosis, conclusive diagnosis, we can use the term that is CFTR related metabolic syndrome. And most of the children may present with a lot of these complaints. We have to follow them till we make a complete diagnosis. So far I have been talking about the diagnosis of cystic fibrosis, particularly the diagnostic aspect. Probably that is my last slide. Thank you very much. Actually, in my experience, this iontophoretic technique, that is pilocarpine iontophoretic technique to diagnose cystic fibrosis, sometimes usually called as sweat chloride, is very, very important. And thank you very much. This is the second part of my cystic fibrosis. First part I have talked about the symptoms. This is the second part about the diagnosis. People who want to see the treatment aspects, we go to the third part of the cystic fibrosis. Thank you very much.